Welcome to the Pediatric Surgery Clinical Vignette Gauntlet. Let's just jump right in, bypass the usual intro, and fire up this high-yield active recall loop. We've got a lot of ground to cover.
Okay, let's dive into this roadmap. Today we're tackling gastrointestinal obstructions, abdominal wall defects, appendicitis and its mimics, and rounding it out with orthopedic and systemic syndromes. And hey, you might notice the warm, approachable visual theme we're using today. That's totally by design to help dial down that exam fatigue. Let's get to it.
Kicking things off with Section 1, gastrointestinal obstructions. We're starting right at the beginning of the developmental timeline with neonatal congenital emergencies. Here is our first clinical prompt. Which of the following is the best investigation in a case of congenital hypertrophic pyloric stenosis? Barium meal, swallow, manometry, endoscopy, or ultrasound? Lock in your guess. If you picked ultrasound, you hit the nail on the head. It's the definitive, non-invasive gold standard here. You're looking for a pyloric muscle wall thickness of 3 to 4 millimeters or more and an elongated channel length of 15 to 17 millimeters or greater. But here is the absolutely crucial example you cannot miss. Pyloric stenosis is a medical emergency, not a surgical one. You have to correct that severe hypochloremic alkalosis and dehydration with IV fluids way before you even think about rolling them into the operating theater. All right, keeping the gauntlet moving, let's look at another neonatal stabilization scenario. What is the appropriate step regarding the management of a newborn with a congenital diaphragmatic hernia? Are we looking at steroids, chest tubes, immediate thoracotomy, immediate laparotomy, or observation of mechanical ventilation until stable? The correct answer is observation and mechanical ventilation until stable. So the crucial point is that the immediate threat to this baby's life is actually pulmonary hypoplasia and severe persistent pulmonary hypertension, not the physical hernia itself. Rushing to surgery, that just worsens lung compliance. Modern protocols are all about delaying that surgery. We prioritize medical stabilization using gentle ventilation with low tidal volumes and permissive hypercapnia until those pulmonary pressures actually normalize. Oh, and for x-rays, look out for the intestine coiled in the hemithorax, the classic botulinum hernia. Next up, a classic two-part diagnostic and surgical challenge. The double bubble sign is the characteristic radiological feature of which pathology, and what is its exact surgical treatment? The diagnosis here is annular pancreas, and the treatment is a duodeno-duodenostomy. That famous double bubble X-ray essentially paints a picture of a complete duodenal obstruction, which happens when the ventral pancreatic bud fails to rotate properly and causes extrinsic compression. Now for the rigid surgical rule, always bypass the obstruction using a diamond anastomosis. You never resect the pancreatic ring because doing that carries a massive risk of creating devastating pancreatic fistulas. Also keep in mind, this condition is strongly associated with Down syndrome. Moving right along to Section 2, we are shifting our narrative focus down to the abdominal wall. Here is a dual-layered question to really test both the why and the how. Why should early primary closure of an exomphalus, also known as an omphalocele, be done? And how exactly does that treatment pathway stratify based purely on the size of the defect? And this brilliantly illustrates how management diverges. For small omphaloceles, meaning under 3 centimeters, immediate primary repair is your gold standard. Getting that gut functioning quickly slashes the reliance on TPN, which in turn drastically reduces the risk of central line infections and systemic sepsis. But if you're dealing with a giant omphalocele, something over 5 centimeters, primary closure is usually unsafe due to severe cardiopulmonary comorbidities. Instead, surgeons use a delayed closure, basically a paint and wait method with escrohiretics like gentian violet or even amnioinversion. Let's look at a pretty dramatic clinical deterioration scenario. A child born with gastroschisis undergoes primary closure. Suddenly, their heart rate skyrockets to 160. Blood pressure tanks to 60 over 0. Oliguria develops, and airway pressures are off the charts. What is your very next step? You have to abandon that primary closure immediately and use a staged celastic silo. Here is the abdominal compartment syndrome cascade. Forcing those herniated viscera back into a tiny underdeveloped abdominal cavity causes intra-abdominal pressure to just explode. This pushes the diaphragm upward, which spikes those airway pressures. At the same time, the inferior vena cava and renal veins get physically compressed. Venous return drops, cardiac preload plummets, and boom, you get severe hypotension and the kidneys stop perfusing. You literally have to open the fascia and relieve that tension to save the patient. Let's move the developmental timeline from neonates to young kids. Section 3.
appendicitis and its mimics. This is a classic diagnostic dilemma that haunts emergency departments everywhere. How do we differentiate true acute appendicitis from its primary mimic in a young, feverish child presenting with abdominal pain and vomiting? It's all about tracking the pain and the exam findings. Acute appendicitis presents with pain that starts periumbilical and shifts to the right lower quadrant, accompanied by persistent muscular guarding and leukocytosis. And remember, kids under 5 are super vulnerable to perforation because their greater momentum is totally underdeveloped. On the flip side, mesenteric adenitis mimics this, but it usually follows a recent viral upper respiratory infection. The tenderness is much more widespread, and if you have the child roll onto their left side, the point of maximum tenderness actually shifts with them. Plus, you won't see true rigid muscular guarding. All right, home stretch. We're transitioning to our final segment, Section 4, Orthopedic and Systemic Syndromes. Let's talk skeletal trauma. Here's your orthopedics prompt. Which of the following Salter-Harris types of growth plate fractures are most commonly encountered in the pediatric age group? Type 1, 2, 3, 4, or 5. Now, what's really interesting about this is that type 2 makes up a massive 75% of these clinical presentations, so that's your correct answer. Let's walk through the Salter mnemonic to map out these structural trajectories. Type I is S for slipped, straight through the physis alone. Type 2 is A for above, through the physis and up into the metaphysis. Type 3 is L for lower, down into the epiphysis. Type 4 is T for through, plowing through the metaphysis, physis, and epiphysis. And finally, type V is ER for erushed, a severe crush injury of the physis, which unfortunately carries the absolute worst prognosis. Okay, final clinical vignette. What will be the likely diagnosis in a young child presenting with facial erythematous skin nodules and mental retardation? The diagnosis here is tuberous sclerosis, which is an autosomal dominant condition. You've got to lock in the classic triad to ensure perfect board exam recall. Seizures occurring in 80% of cases, adenoma sebaceum in 75%, and mental retardation in about 60%. To quickly run through the whole picture, just use the hamartomas mnemonic. Hamartomas, angiofibromas, mitral regurgitation, ash leaf spots, cardiac rhabdomyomas, and of course, tuberous sclerosis itself. The difference between an adequate physician and an exceptional one lies in mastering the why behind the what. So the real question is, are you ready to apply these pathophysiological whys to your next clinical shift? Thanks for running the gauntlet with us today.